And open up wide. Okay, let's get the left side first. To the right side.
It's completely supinated, and you're going to ask them to bring the tip of their thumb to the tip of their pinky. So Courtney does not have a deficit. However, if she did, what you're going to do is you're going to measure from tip to tip in centimeters and document the deficit. So she would be, if this is our deficit here, she would have like a 3.5 centimeter deficit to full opposition. And that's what you would document. To test the muscle strength, you're going to hook here and hook here. Bring her almost together and just ask her to hold it. So I'm gonna pull you apart. You try to bring them together. Good.
Do your thumb first.
And what you need to do is to immobilise the metacarpal and then see whether you can move the phalanx more than it would normally move. So the ligament is here. By trying to open the joint up in this direction, you're stressing that ligament to see whether it's intact or not. And this should be done both straight and flexed. So having worked out what's normal for that patient, you then come across to the injured hand and you see whether it's the same on that side or not. Both straight and flexed. Whether it's the same as another finger. So I would simply say, does that feel the same as that? If the patient has any difference at all in their sensation and there is a laceration, stabilise the metacarpal, which if you've got large hands you can do it around their hand. So I'll stabilise the metacarpal and I want to see how much movement there is of the proximal phalanx. So by moving it in radial deviation, I'm stressing the ulnar collateral ligament. I want to do that both in extension and flexion. And in this patient, there is good, complete block to movement in the radial direction. In order to know what's normal for this patient.
Again, just 1 second now, and back in and out. And in. That's it, and out again. Thank you. And just back in again and out again. Just 1 second now, and back in and out and in. That's it, and out again. Thank you. And just back in again and out again. Just 1 second now, and back in and out.
The biggest cause of dehydration to the skin is transepidermal moisture loss. But another reason is harsh chemicals, harsh soaps, and alkalis. When we strip off the surface of the skin too much.
And we test for the sensation of the tips of each of the fingers, remembering to test for both sides of the ring finger. And we also assess sensation on the dorsum of the hand. And remember that the autonomous zones are median nerve, ulnar nerve, radial nerve. So that's median nerve, ulnar nerve, and radial nerve. Take this hand, now bend that one down, that one down, that one down, that one down, and the thumb. Now bend that one up, that one, that one, that one. The radial nerve, lift up the wrist, hold it up, fingers up, hold them up, lift the thumb up to the roof, hold it there, that's great. Now on this hand, lift the thumb up to here, that's great. Put the two together, hold tight, relax. Check for wasting. Open the fingers wide, keep them apart. Lift this one up against my finger, test for the first dorsal interosseous, and we test for the adductor power, hold tight, relax, tight, relax, tight, relax. Hold the paper like that, try and take it away, that's great. Sensation, there, on the dorsum, and then that one, that side, and that side. Now, what I want you to do, open and close the fingers.
Meaning IP extension. So you're going to flex this, but I want you to keep this straight. Okay, stop for a second. Flex it just like that. I just want you to bend this joint. I want you to keep this straight. Okay, there you go. Try to keep that straight. Don't let me push it back up. Okay. You try to keep that straight. Can you keep that? There you go. Hold it right there. Hold it. Hold it. There you go. That's what I want.
You really have to think about that.
Mm-hmm. Okay. So that's MCP, flexion. Thumb, IP, back up here, extension. So that means we're going to have to start in flexion, is what it's telling me. Patient is sitting, form is in mid position. The wrist is in neutral. The thumb is adducted with MCP joint is extended and the IP joint is flexed. So this is staying like that, that's staying like that. And then it says the patient extends the IP, so I want you to just straighten that. Don't let me push it back down. Awesome. Okay. Perfect. I'm gonna do it again. This is what it looks like. Straighten it. Don't let me push it back down. Okay.
Then passively flex the MCP joint while keeping the IP joint extended to end range. And then have the patient actively do so. Then apply resistance on the volar surface of the proximal phalanx of the first metacarpal, or the first digit. The proximal phalanx of the thumb and palpate the tendon of the flexor pollicis longus on the volar aspect of the proximal phalanx. Then passively flex the IP joint to end range and ask the patient to do so while palpating. And then apply resistance to the volar aspect of the distal phalanx in the direction. Passively extend the MCP joint while allowing the IP joint to stay flexed. And then passively extend the MCP joint while allowing the IP joint to stay flexed. And abductor pollicis longus and brevis. Passively move the thumb into abduction and have the patient do so while palpating. And then apply resistance to the first metacarpal bone in the direction of CMC adduction for abductor pollicis longus. And then on the proximal phalanx of the first digit for
MC motion, and the other hand is what is going to be giving resistance to MP flexion of the proximal phalanx, and you're going to be doing this in the direction of extension. Now to begin the manual muscle test, I'm going to have the patient
and go ahead and flex, flex, hold it there, don't let it move you. Good. Here, go ahead and flex, hold it there, don't let it move. Good. The next thing we're going to do is extend.
Then passively flex the MCP joint while keeping the IP joint extended to end range. And then have the patient actively do so. Then apply resistance on the volar surface of the proximal phalanx of the first metacarpal, or the first digit. Of the thumb, and palpate the tendon of the flexor pollicis longus on the volar aspect of the proximal phalanx. Then passively flex the IP joint to end range, and ask the patient to do so while palpating. And then apply resistance to the volar aspect of the distal phalanx in the direction of IP extension. Passively extend the MCP joint while allowing the IP joint to stay flexed.
Good. Okay. Now flex here. Hold it there, don't let me move you. Hold it there, don't let me move you. Flex, hold it there. And flex, hold it there, don't let me move you. Good. Bring your thumb out and go ahead and flex, flex, hold it there, don't let me move you. Good. Here, go ahead and flex, hold it there, don't let me move. Good. The next thing we're going to do is extend.
Proximal phalanx of the thumb and palpate the tendon of the extensor pollicis longus on the dorsal side of the first metacarpal and proximal phalanx of the thumb. Then passively extend the IP joint into end range, and then ask the patient to do so while palpating. Okay, and then apply resistance to the dorsal aspect of the distal phalanx with one finger. For thumb abduction, the abductor pollicis longus and brevis, the patient is seated with their forearm supinated and supported on a flat surface with their wrist in neutral and their thumb adducted. Stabilize at the volar surface of the wrist in 2nd through 5th metacarpals and palpate the abductor pollicis longus and brevis. Passively move the thumb into abduction and have the patient do so while palpating. And then apply resistance to the first metacarpal bone in the direction of CMC adduction for abductor pollicis longus, and then on the proximal phalanx of the first digit for